the good thing about the installations is that the chemical doesn't get absorbed into the body. So there's no other systemic general side effects. You don't get thrush or other problems that you would with oral antibiotics.
I'm speaking with Dr. Sachin Malde, a UK-based urologist with a number of specialties, including recurrent UTI, bladder cancer, and prostate disease, and we're going to cover a few of those. Thanks so much for taking your time to answer our community's questions.
Thank you, Melissa, for inviting me. I think it's a great platform. So as you say, I'm Sachin Malde. I'm a urologist here in London in the UK. I'm a functional urologist, so I specialize in kind of different aspects of bladder diseases, and I have a kind of specific area of interest in recurrent infections, chronic infections, bladder pain, as well as bladder cancer and prostate enlargement. So it's a pleasure to be here today.
Great, thanks so much. So first off, we're going to talk about bladder installations. It would be great if you can explain what bladder installation means for those who are not familiar with the process.
Yeah, so a bladder installation essentially is filling the bladder with a chemical or a solution through a catheter. The aim is then that solution stays in place in the bladder for a certain amount of time, and then the solution is drained out. And the aim is that that chemical, that solution should be used to treat certain bladder conditions. So we use it for bladder cancer, chronic cystitis, for example. So different conditions can be treated with installations of chemicals into the bladder directly.
So a lot of people are becoming more familiar with antibiotic bladder installations, but you just mentioned bladder cancer, and we know that some people are given installations to manage pain. What might be in the other installations that are not antibiotic?
So the non-antibiotic installations typically that people use for bladder pain involve using chemicals that replace what we call the gag layer of the bladder, so the glycosaminoglycan layer. They're the commonest type of non-antibiotic installations for bladder pain. And the normal bladder is lined by this kind of tight barrier lining called the gag layer. And it's made up of different chemicals like heparin, hyaluronic acid, chondroitin sulfate. And it's thought that this layer kind of protects the underlying nerves in the deeper parts of the bladder from any of the irritant chemicals and toxins and bacteria in the urine. But in people with bladder pain, one of the theories is that layer gets broken down a bit or gets a bit damaged. So these toxins can then penetrate a bit deeper into the bladder, irritating these nerves and causing pain. So these kind of gag layer replacement treatments, and there are lots of different ones out there. The theory is that they would then kind of replenish that layer, kind of heal up that gag layer, and therefore improve pain. And there are lots and lots of studies on these treatments, but the quality is quite variable overall. But lots of patients do find even the non-antibiotic installations quite useful for pain relief.
Is that a type of installation that you use in your own practice?
I do. So the commonest, I would say, that I use is an antibiotic installation, because majority of women I see at the moment, or patients I see at the moment, are suffering from underlying chronic infection causing their symptoms. So I think if I thought there was definite bacteria or embedded bacteria as the trigger for their pain, then I would use an antibiotic installation. But if even after using extended cultures, for example, we don't find bacteria, then even these non-antibiotic installations as a symptomatic treatment do work well for some people.
I've heard the theory that using the heparin or the gag layer base installations is a bad idea if you have chronic infection, because it may just be kind of sealing it into the bladder. Do you think that might be the case?
Yeah, it's a good question. I've heard that a lot from patients as well. And theoretically, you think that makes sense. I mean, that's why ideally for infection-causing bladder pain, I would go for the antibiotic. I'm not sure if it seals it in. To be honest, I think the evidence is really weak for that. Although patients with UTI have been studied, and some of the trials do report kind of good results with it. But I kind of feel that if there's definite bacteria causing it, then I prefer to target that with antibiotics. I think it tends to be more effective.
Okay. A few people said in the past they've had installations with Betadine or other antiseptics and asked if those types of installations are still used today.
That's a really interesting question, actually, because it's something that I've been considering a lot, mainly as part of kind of research studies. You're absolutely right that irrigating the bladder with kind of antiseptics, such as povidone iodine, for example, was described. I think there were some early studies in the 1980s looking at this, and they were kind of variable in terms of the outcome. So some studies kind of said, yeah, it works quite well, and others said, well, it doesn't really do anything. But there's actually been a lot more interest in this recently, and there's been a couple of studies published just in the last year or two about irrigating either the urethra in men before a cystoscopy or instillations of Betadine, and actually report really promising results. So I think it's definitely something I think to consider. It's definitely something we're interested in. I think it does need kind of further study, but I think for potentially for a lot of women it could work well.
I think there would be a lot of interest in our audience for that. There's a lot of questions we receive around HipRex, the last interview series that we did, and antiseptics potentially have less risk of antibiotic resistance, though the studies would need to be done, obviously. But our community is very interested in the space. So if you move forward with research in that area, I'm sure we could help find recruits for that.
Excellent. Yeah, very good.
So what type of antibiotics can you use in an installation? I assume it's not just the same as what you can take orally.
Yeah, it's not the same. And the reason is because just because of the way antibiotics, different antibiotics are made and the formulations they come in. So not all antibiotics are directly transferable to a kind of instillation. The commonest by far is gentamicin. So this is a kind of typically an antibiotic we use intravenously when patients become very unwell or septic and come into hospital. But that solution has been studied a lot for bladder instillations. And a similar drug called amikacin is another antibiotic we commonly use. But apart from that, gentamicin and amikacin will work very well for the majority of kind of typical UTI causing pathogens. But some, for example, Enterococcus, typically tend to be resistant to gentamicin. So in that situation, we've started using vancomycin to try to target the Enterococcus. But yeah, it's not direct. Not all antibiotics can be used for installations.
Can all clinicians access these solutions for installation, or do they have to work with a compounding pharmacy or a specialist pharmacy?
Yeah, that's a good question, because in fact, the vancomycin, I've started doing after speaking to another specialist in the United States. She's got a lot of experience with vancomycin. So, but there is a specific formulation to be used, and you do for vancomycin need to work with a compounding pharmacy to get the solution made up in the right way. With gentamicin, it's much easier.
Have you found it possible in the UK to get those solutions made up?
I have recently. So I have now, kind of after working out the formulation and having advice from specialists in the US, got kind of a regime we can use for vancomycin.
Oh, that's good to hear. What's the recommended frequency of antibiotic installations? And does your approach ever differ from what is standard? Because I know there is a lot of difference between the approaches of clinicians here.
Yeah, and here, to be honest, it varies. It varies massively. I think there's definitely no set kind of standard schedule that everyone would say, yeah, this is the best way to do it. In fact, lots of centers do it differently. Even in the studies, the regimes used vary. So some places do once a week in hospitals. Some would go down to once every 2 weeks or once a month. Some places every day or even twice a day. So there's a massive variation in that. And to be honest, there's no study that says one is 100% definitely better than the other. In my own practice, we tend to use a daily installation for 2 weeks, every day for 2 weeks. And then we try and wean it down slowly to stay on the lowest frequency that keeps infection away. So that may end up being alternate days or twice a week. or once a week, depending on how patient symptoms are.
Do you think that spacing out the instillations increases the risk of antibiotic resistance?
It's a good question. I think that's why we, when we were kind of planning our original regime, we decided to start with daily because I think if you use gentamicin instillation, the antibiotic concentration going into the bladder is much higher than, with, for example, an oral antibiotic. So it's likely that with a daily instillation over 2 weeks, that's a very kind of high therapeutic dose. And then by weaning it slowly, hopefully, we think that you end up treating or killing bacteria as a proper therapeutic treatment before going to lower doses. And we only really go to lower doses when symptoms are very well controlled. So that hopefully that means that infection and chronic infection has been cleared before we start weaning it down. And the weaning then is, and the maintenance dosing or the weaning then is really just to prevent new bacteria forming. And so far, we've not seen, at least with gentamicin, not seen a lot of resistance developing to gentamicin.
Okay, that's good to know. Once the antibiotic is instilled in the bladder, how long should the patient hold it in?
That's a good question. So I ask patients, ideally, the longer they can hold it in, the better. If some patients do it just before bed and can try and keep it in overnight, then it's likely to be more effective. One of the downsides of bladder installations is it really does depend the effectiveness on how long you keep it in the bladder, how dilute the urine is. So I normally ask patients not to have anything to drink for an hour before or 1 hour after the installation. Ideally to keep it in for at least 1 hour, but if they can do 2, 3, 4 hours, then that's better. And hopefully that would then just kind of improve the effectiveness of the installation.
Does the instillation coat the bladder so it's not all lost when you urinate, or is that time you hold it in the only time it's active?
Well, there have been some studies looking at whether just passive installation like this achieves good kind of tissue penetration into the bladder. In other words, does the antibiotic get into the bladder? And probably not massively. It probably doesn't get that deeply into the bladder tissue. But I think the installation, of course, while it's there, it works. I think there is also some superficial kind of penetration of the urothelium, the topmost linings. I think there is still some ongoing effect, even once it's washed out. But I suspect that's probably minimal.
Can antibiotics delivered via any method, so IV, oral, or instillation, you just mentioned that a little bit, but can they penetrate the bladder tissue?
Well, it does happen. So with intravenous and oral antibiotics, there will be some tissue penetration. So it does, small amounts do get into the bladder tissue itself, but actually the amount that gets into the bladder tissue is quite low. And so there are other groups, and even we trying certain things to see if we can get antibiotics to penetrate deeper into the bladder.
Okay. Is it something that patients can do at home, or does it need to be done in clinic?
No, it can be done at home. It can be done at home. So our usual practice is to do the first few installations in clinic, just to get patients used to it and to make sure they don't have any particular issues with it. But after that, we train patients to do the catheter and to draw up the chemical and put it into the bladder themselves. And although it can be quite daunting at the start, actually we have a very good team of nurses and pharmacists actually who train patients in all of this. And actually, a lot of patients come back and say, "Oh, it's a lot better than I thought it was going to be."
That's good.
They tend to get used to it as soon as they start doing it. And the good thing with that is they're in control then of their own treatment. They can kind of manage it however they like.
Yeah. And let's talk a little bit about possible side effects. Can installations of any type cause discomfort or burning in the bladder?
Well, yeah, they can do. The process of the catheterization can sometimes irritate the urethra with some discomfort, which is why we tend to use a very small catheter. So it's not normal sized catheter. Normally, patients would have a 12 French or 14 French size catheter. For the installations, we use a much smaller one, normally around 8 French, to try and minimize that discomfort. Normally, that discomfort only lasts for kind of a few hours. it's uncommon to get really any more discomfort or flare up of symptoms more than that time. The good thing about the installations is that the chemical doesn't get absorbed into the body. So we know that from doing blood test levels of gentamicin, for example, that it doesn't get absorbed. So there's no other systemic general side effects. You don't get thrush or other problems that you would with oral antibiotics. But the downsides, I think, are just the fact that it does involve using a catheter, the process of putting the chemical into the bladder, and the initial irritation that might come with that. But otherwise, no, it's a very good treatment.
Is there an increased risk of new infection being introduced because of the use of a catheter?
So there's potentially a very small increased risk because you're having a catheter go into the urethra. It may take bacteria with it, but the chance of infection from the catheter alone, generally, we would say is probably around 1%, very low. And the advantage of this is that because an antibiotic is being instilled at the same time, it's likely that any organisms that go in with the catheter would be killed by the antibiotic itself. So actually the risk of new infection from the catheterization with this treatment is much lower.
Okay. If the infection location is actually the urethra or the ureters or kidneys, will a bladder installation provide any benefit?
Unlikely. I mean, definitely if it's ureters or kidneys, it's not going to provide any benefit unless the infection of the ureters and kidneys is what we call ascending infection from the bladder. Then it will clear the bladder organisms, but it wouldn't actually treat a kidney infection or urethral specific infections as well. It's because it's not in contact with the urethral surface for very long. It's unlikely to make any real difference for that.
Okay. Do you think that bladder installation might be a good option for people who experience C. diff with oral antibiotics?
Absolutely, absolutely. So I have a lot of patients who have bad side effects with antibiotics, including C. diff, or they get bad thrush, or have lots of allergies to oral antibiotics. And actually, the installations are a good option for those patients because it avoids all of those issues.
Do you ever recommend that patients use both bladder installations and oral antibiotics simultaneously?
Not commonly. Not commonly. So in my mind, the installations really are ideally an alternative to oral antibiotics. And so the aim is they should replace the need for long-term oral antibiotics. I think some patients, obviously with installation, it's not just a kind of 2-week course. Some people need to use it for longer periods. But so normally I would recommend, if patients can take oral antibiotics, that's my normal initial recommendation. But only if for some reason they can't use oral antibiotics, I would recommend gentamicin, but usually alone without any oral.
Okay. That makes sense. Can you estimate what the success rate of treatment is with bladder installations?
Well, yeah, I mean, there's lots of there are lots of kind of case series and studies out there describing people's experience with gentamicin. Obviously, the regimes differ, so it's not kind of possible to say a kind of exact figure, but generally, all the studies tend to quote success rates of around 70 to 80%.
Okay.
And I think patients, in terms of improving the number of infections, improving symptoms, and that's probably what I see in my own practice. Is probably 70 to 80% of people who use, who haven't been able to use or haven't done well with long-term oral antibiotics to improve with bladder installations.
Okay. Is the bladder installation something you could use as self-start treatment for an episode of UTI symptoms, or is it not the same as oral antibiotics in that way?
No, it's a good. It could be used actually. That's an interesting point. When patients who, for example, are on gentamicin established and kind of doing very well, sometimes it may be a year later, for example, they have a flare up of some symptoms, and often we recommend they just do another installation at that time, and it often does get on top of things. Okay,
that's good to know. And there was one last question. What proportion of your patients do you think would be on installations as opposed to oral antibiotics for UTI?
I would say probably around 20%. So I think the majority are on oral antibiotics. Because we offer the installations, I think we see more patients coming specifically for that.
Okay.
So 20% may be slightly higher even than some places, but I think I would say majority on oral antibiotics.
Okay, great to know.